Hello, I'm Eileen Wang from National Jewish Health, and I'm joined by Dr. Michael Wexler for this clinical brief on defining severe asthma and recommendations for the use of biologics. We'll first review the GINA definitions, which we all recognize for uncontrolled asthma, difficult to treat asthma, and also severe asthma. So it's important to know for uncontrolled asthma, we're thinking about both symptom control, and that's reliever use, activity limitations, nocturnal awakenings, but also exacerbations, including those that are serious exacerbations requiring hospitalization. For difficult to treat asthma, it's uncontrolled symptoms despite use of medium or high dose inhaled corticosteroids with a second controller. So that's usually that long acting beta agonist or maintenance oral corticosteroids, or that you require the need for this high dose treatment to maintain your good symptom control and reduce that risk for exacerbations. Severe asthma is uncontrolled symptoms despite this adherence to maximally optimize high dose ICS-LABA and also management of those contributory factors. So key comorbidities that may be exacerbating your asthma or your asthma that worsens when this high dose treatment is decreased. In terms of phenotyping and endotyping patients with severe asthma, GINA guidelines recommend determining if that patient has that type 2 airway inflammation in order to offer this personalized treatment. So in terms of definitions of type 2 inflammation, GINA defines this as having one or multiple of blood eosinophils of at least 150 cells per microliter, fractional cell nitric oxide or FeNO of at least 20 parts per billion, sputum eosinophils of 2% or more, and also asthma that's clinically allergy driven. It's also important to note that these are not static in time and they can be impacted by the natural history of asthma and also therapeutics such as corticosteroids. So it's important to consider repeating these biomarkers, including the blood eosinophils and FeNO, up to 3 times, and ideally at least 1 to 2 weeks after an oral corticosteroids, or if you're not able to completely discontinue oral corticosteroids, then on the lowest possible OCS dose, as that does suppress a lot of these type 2 biomarkers, and you can actually see it come through when you are able to take them off. Along with the updates in GINA 2022, we have recommendations for the assessment of severe asthma phenotypes and the factors that contribute not only to symptoms, but also quality of life and exacerbations. So again, you'll see that consideration that add-on type 2 targeted biologic therapy for those with exacerbations or poor symptom control despite use of the high ICS-LABA and who also have that type 2 inflammation. It's also important to consider local payer eligibility criteria, key comorbidities, or predictors of response, and also cost, dosing frequency, the route, whether subcutaneous or intravenous, and also patient preference for that shared decision making. So when you're considering which biologic is appropriate to start first, we have this table here with the eligibility and also the predictors of asthma response. So starting at the top, we have anti-IgE, which is omalizumab, indicated for severe allergic asthma. And for eligibility, you want to see that sensitization of aeroallergen sensitization on either skin prick testing or specific IgE. You want to see that total serum IgE and weight are within the dosing range and also evidence of exacerbations in the last year. But when you're looking at predictors of good response to omalizumab, things that can predict good response are evidence of that type 2 inflammatory pathway. So increased blood eosinophils, high FeNO, allergen-driven symptoms. So that patient with grass allergy who exacerbates, in the springtime when the grass pollen is most predominant, and also a history of childhood onset asthma can be a predictor. Now, for the family of the anti-IL-5 and anti-IL-5 receptors, that includes benralizumab, mepolizumab, and reslizumab, and that's indicated for severe eosinophilic asthma. You're looking at evidence of blood eosinophils that are increased and also exacerbations in the last year in terms of eligibility. Factors that can predict good response to this family of biologics include higher blood eosinophils. More exacerbations in the previous year has been shown to be a pretty strong predictor. Also adult onset asthma and evidence of other comorbidities that's associated with peripheral eosinophilia, such as nasal polyps. For anti-IL-4 receptor, or dupilumab, which targets the IL-4 and 13 pathways, this is indicated for that severe eosinophilic or type 2 asthma, but also oral corticosteroid-dependent asthma. So you're looking for eligibility in terms of the exacerbations, evidence of loss of control, and also blood eosinophils, which typically are recommended to be between 150 and 1500, and it's limited at that 1500 cells per microliter for a baseline blood eosinophils because of the risk, the low of that transient decreasing hypereosinophilia, which they did see in the dupilumab trials. Also, that elevated FeNO, reflecting that IL-13 pathway, which dupilumab targets, or you're taking your maintenance oral corticosteroids. Factors that predict good asthma response to dupilumab include those type 2 biomarkers, so high blood eosinophils, high FeNO, very strong predictor. Lastly, in terms of anti-TSLP or tezepelumab, which received FDA approval at the end of 2021, this is indicated for any phenotype of severe uncontrolled asthma, so you don't need to have evidence of type 2 inflammation, as it was shown to be effective in both, which Mike will go into more detail. So you're just looking for eligibility in terms of that exacerbations in the last year. However, there are factors that predict improved response to anti-TSLP, and that includes that group with a higher type 2 biomarker, so the higher blood eosinophils and FeNO.
Thanks, Eileen. So we are fortunate that now in 2022, we have several biologics that have been approved by the FDA, including omalizumab that targets IgE that was first approved in 2003. It's really for patients with more allergic asthma. It's approved down to age 6. Mepolizumab was the first anti-IL-5 therapy approved in 2015, and this is for patients with eosinophilic asthma. Reslizumab is an IV preparation, also approved for eosinophilic asthma, but only down to age 18. And benralizumab is an interleukin-5 receptor antagonist that is important and effective therapy for patients with eosinophilic asthma as well, also approved down to age 12. More recently, in 2018, we had the development and approval of dupilumab, an IL-4 receptor antagonist for patients with moderate to severe asthma, characterized by either eosinophilic phenotype or for patients who had oral steroid-dependent asthma. This therapy had already been approved for atopic dermatitis and has since been approved for other comorbidities, including chronic rhinosinusitis with nasal polyps, as well as eosinophilic esophagitis. The last therapy that was approved in December of 2021 is tezepelumab, which is a monoclonal antibody that targets TSLP. It works across the spectrum of type 2 inflammation and also improves airway hyperresponsiveness. It's indicated for patients with severe asthma. How do these biologics fare in terms of their efficacy? Well, they all do quite well. They all reduce exacerbations in the correct patient populations. For the most part, they all improve asthma control questionnaire. And there is a fair amount of improvement with FEV1, particularly for benralizumab, dupilumab, mepolizumab, reslizumab, and tezepelumab. Quality of life measures improve in all of these, and there are good data in terms of oral steroid reduction with benralizumab, dupilumab, and mepolizumab. So we have a lot of good drugs, a lot of indications, and a lot of efficacy for our patients.